you can hear it. So neural tumors are interesting. There's quite a few of them. You do need to know these for the board examination. They're probably not going to get into showing you any esoteric lesions. So we're going to really go over some of the more common ones that you'll be potentially liable for on the board examination. So the first one is a neurofibroma. And I'd like you to think about neural tumors from the standpoint of the normal anatomy of a nerve. So, and again, you don't necessarily know endoneurium, epineurium, and perineurium, but you can think of a nerve as almost like a wire or maybe a cable is maybe a better way, that's got multiple little wires in it, and the wires are the axons. And then surrounding the axons are obviously the Schwann cells. And then we also have a few other cells in that stroma. We have mast cells. There's actually potential space in there where there's cerebrospinal fluid that's actually lubricates the individual nerve. So it really is an electrical circuit, if you will. And so if you are inside this little cable where all these little, wires are going on, and if you were, say, a little miniature man, so I don't know if you guys have ever seen the movie Fantastic Voyage that originally came out in the 1960s, I believe it was, with Raquel Welch. I recommend that you see that. At the time, it was considered a really innovative medical movie. And basically, if you were to shrink down to the size of the little spaceship that's going through the guy's body and go inside a nerve, and if you were then just to have an explosion and it blew up like this, all those little wires, the axons, would basically be spread diffusely in that explosion. And you would have mast cells and perhaps a few fibroblasts and some mucin and whatnot in the stroma. That's the way a neurofibroma really, you can think of it as developing that way, that it's basically almost kind of a neoplasm that sort of theoretically kind of starts off in the middle of the nerve and then it sort of expands outward. A schwannoma, on the other hand, is if you've got your cable here, and there's sort of like a tumor that develops at the periphery of it, and then it sort of forms this bulbous aggregation off the side of the cable. And you will often see in a schwannoma, which is again a neoplasm, a non-neoplasm of Schwann cells. So I think there's a few Schwann cells sitting on the edge of our little cable here, and they start growing and forming a tumor. That tumor gets big and it compresses that cable off to the side. And you'll often see a residual nerve twig, a relatively large nerve twig off to the side of a schwannoma. If you were to do a complete excision of that, you would. And if you ever seen an autopsy or surgical specimen of that in the Gross laboratory, you actually then will see the nerve and then the schwannoma off to the side. So basically, those are the two main ways of getting nerve neoplasms. So you can think of it that way. It kind of keeps it in your mind, so at least makes some sense. So this is a neurofibroma. And here you see all the little axons in the middle of it. You see the stroma with the Schwann cells and its fibromyxoid. This is mucin over here. So anytime you get mucin in the skin, you always have mast cells in there, almost always. So this is a nice example of a neurofibroma. And notice it's a dome-shaped papular lesion. And most of these are just solitary. They don't mean anything. Of course, obviously, if there's someone that has von Recklinghausen's disease, you're going to get a lot of them. The other kind of board pearl to remember is if you get a plexiform neurofibroma, you should think in terms that the person might actually have, neurofibromatosis. So that's something that can be seen in that situation. We'll often even report it to the clinician if it's a plexiform schwannoma, that the person might actually have neurofibromatosis. And this is another example. This is a plexiform neurofibroma. And I noticed the way that the biopsy was taken. It's taken by what looks like probably an enucleation technique. This was probably sitting beneath the skin surface as opposed to the last one, which was sitting above the skin surface like a little sessile papule. Here we're looking at something that was probably felt like a bag of worms. So they probably thought, well, this may be a cyst, maybe a lipoma. Let's do an incision over it and then see what pops out. And this is what came out. Again, it's this proliferation of these little fine Schwann cells, and some axons are probably mixed in here as well. It's hard to see those, but most 99% of the cells that you see here are Schwann cells. So we talk about that explosion, if you will. It's really a massive proliferation of Schwann cells, but they're inside the nerve and they kind of grow out like this, as opposed to being on the outside of the nerve like a schwannoma. So this is a plexiform neurofibroma, and notice that it's got these multiple aggregations together. So you're talking about one neurofibroma, two neurofibromas, three neurofibromas. It's like a cluster of grape slash, if you will, of neurofibromas all clustered together in this plexiform mass. And clinically, these may present at these large pendulous folds that look like the elephant man. And the elephant man actually didn't have neurofibromatosis. It turns out he had Proteus syndrome. But that's what plexiform neurofibromas can look like. You look similar to that. You need to know a lot about neurofibromatosis. I highly, highly recommend spending lots of time studying that syndrome. You need to know every cutaneous manifestation, Crow's sign, axillary freckling, all that sort of stuff. Know everything there is to know the genetics of neurofibromatosis. You will get asked lots of questions about that on the exam, and since you know it's going to happen, it's pretty easy. You can master it, and you don't have to. You'll get all the questions right. Now, this, in contrast, is a schwannoma. And notice, first of all, it's deep to the skin. These almost never are superficial and never give you like a little papule like we see with a neurofibroma, kind of a classic papular neurofibroma. It's more like a deep lesion, and these are usually misdiagnosed clinically. They're usually thought to be cysts or something like that. So when the clinician, they'll usually do a nucleation biopsy like this, they'll slice into it, and these things will just kind of pop out. And that's the way that a lot of the adnexal tumors also will kind of come out of the skin. So here, remember, our tumor developed at the edge of the nerve twig. So this is probably that nerve twig right here. And then coming kind of right off the edge of it, we have this proliferation once again of Schwann cells. Now, and there's a mast cell right there in the stroma. So one other thing that we've talked about before in some of the other lectures is distinguishing between spindle cell neoplasms in the skin. How do you tell one spindle cell lesion from another? And they can sometimes be a little bit challenging to do that. Most of the time we can tell. Usually a Schwann cell or a nerve differentiation, which the vast majority of them are Schwannian, will demonstrate this sort of lazy S morphology to them. Like you see here, this sort of delicate, lazy S sign-shaped sort of spindle cell. And you see it over here. They're not jagged and moving kind of like zigzags like we see with, say, like a fibrosarcoma, for example. It's not demonstrating that sort of basket weave storiform pattern that we see with the dermatofibrosarcoma, although some people think DFSP may be in the neural category. And it's not demonstrating these blunt cigar-shaped morphology with a periapical vacuole that we see with a muscle lesion, smooth muscle differentiations. Those are the three main types of spindle cells that we see in the skin. Of course, if we're not sure, we can always do immunoperoxidase staining, but it's really better to learn how to recognize things with H&E morphology and then supplement it with the stains if you need it. The stain shouldn't be the primary thing that we do. It should be kind of a secondary phenomenon. So here we've got this nodule that's deep to the skin, and it's got the Schwann cells that are forming the bulk of the process. And we don't really have too terribly many of what we call barricade bodies. There's two main types of schwannomas. Also, another synonym of that is neurolimoma. Basically, neurolim means the sheath, if you will, the outer lining of a nerve. So the Schwann cells are neurolimal cells. So generally, we'll see barricade bodies in the type A schwannoma, and we don't see those in the type B schwannoma. The type B sort of just gives you mucin and a lot of these Schwann cells, but not usually to the same degree and more cellular than most neurofibromas. So this one doesn't really have a lot of barricade bodies at all. So this one I probably would just call either a neurolimoma not otherwise specified, or I would maybe say possibly a type B neurolimoma. Usually those have a little bit more mucin and more of a myxoid stroma. Now, one other feature that can help you with distinguishing nerve differentiation from muscle differentiation, if you're kind of looking if you're not 100% sure, nerve lesions, for some reason, and I don't know the answer, I'm not sure anybody knows the answer to this, they give you this very marked PAS positive basement membrane zone around the blood vessels in the lesion. That's very characteristic, especially of schwannomas. Not as much in neurofibromas, but in schwannomas, they often will have this morphology of the blood vessels. There are other conditions that give you that. For example, porphyria will give you this sort of thickening of the PAS positive basement membrane zone around the blood vessels. So I don't understand why it's present in a schwannoma, but it's also present in porphyria, but it is. So that's pretty characteristic of that. So that's just kind of a schwannoma, not otherwise specified. Here's another example. Again, these things are kind of fun to look at. And this one has got some barricade bodies looking like they're kind of trying to form over here. The way I like to think about barricade bodies, they're Schwann cells that line up kind of across an acellular zone in the center. Here's one over here. If you really get them in nice cross section, they really, this is much better up in this area here. So I like to think of it as a couple of armies here, like maybe the Greeks on this side and the Trojans on this side, and this is the plain of battle, and they're getting ready to just attack one another across this plain. So that's one way you can kind of think about that. And so these are barricade bodies, and A rhymes with type A schwannoma. So, or neuroma. So if you want to remember that, barricade type A, and they look like armies getting ready to attack one another. That's a barricade body. And these are not painful tumors. Okay, right. We know that neuromas, I'll talk about that, I think a little bit later on. Yeah, basically, those are one of the painful tumors in your Bingle or Angel mnemonic that you use. These are not painful. So even though they're neurolenoma, which could be an N in that thing, just don't get confused. Remember, these are usually not painful at all, even though they are associated with nerves. So this is more of an Antoni B. So notice you can tell it from a neurofibroma. It's far more cellular than a neurofibroma. It doesn't have any barricade bodies. It does have some mucin in the stroma. But basically, if you see a cellular lesion comprised primarily of Schwann cells like this, it's with some mucin, but without any barricade bodies, that's an Antoni B schwannoma. Now, I don't think the board's going to get too detailed on schwannomas, so don't worry a lot about these, but at least you know the answer. If you get a question about it, you'll be able to answer it correctly. And just like we have plexiform neurofibromas, occasionally get a plexiform schwannoma. And I'd be super surprised if you get this on the exam, but basically it's just another kind of example of the way that these interesting nerve tumors can present in the skin. So if you look at any one of these little individual aggregations, here you see some Antoni A barricade bodies in here. So if you just looked at this one little thing in isolation, wow, that's an Antoni A neuroloma or schwannoma. But then you look and see that there's about 50 of them, all here together forming a solid little mass that probably, just like the plexiform neurofibroma, probably felt like a subcutaneous bag of worms-like lesion. So this is a plexiform schwannoma, plexiform neuroloma. This is not associated with neurofibromatosis. Not sure it's really associated with much of anything, but it's just an interesting variant that you can see in the schwannoma family. So that's plexiform schwannoma. Now, sometimes you'll get one of these nerve tumors that's been around for a long time, and they can start to take on some kind of funny histologic morphology. And I'm going to show you some of these areas. The cells begin to look kind of large. They look sort of pleomorphic. Some of the nuclei may be really large and kind of irregular, and like you see over here. This is what's called ancient change. Basically, some people also refer to it as symplastic change. And basically what that means is whenever you get one of these neural tumors in particular that's been around for a long, long time, the cells start looking hyperchromatic and may develop some pleomorphism, maybe get an occasional mitotic figure. And probably most of the time, it's just kind of a histologic finding. But one of the things you do have to be a little bit concerned about, especially if you start seeing mitoses, is the potential that this thing could potentially be developing into a low-grade peripheral nerve sheath malignancy. And we do know the patients have neurofibromatosis. They do have a higher incidence of the development of neurofibrosarcoma. So we do get concerned when we see lesions that are large and they start developing some atypical areas in there, especially if they're mitotic figures. But if there aren't any mitotic figures, or maybe just one or two, and they just have these sort of unusual morphologies to them, like we're showing you here, that basically is not major cause for concern. Clinically, if these lesions begin to change or grow, that can be a cause for concern, and you want to make sure that you will biopsy such an area. One thing about soft tissue tumors, and neural tumors are included in this category, is that they can be so-called multiphasic. It can be biphasic, where that means you have two different morphologies in the same tumor. It can be multiphasic, where you have multiple different morphologies in the same tumor. And so if you just biopsy one area, you may get an area that looks totally benign, and there may be an area that's undergoing malignant degeneration sitting maybe just adjacent to that. So you have to always be aware when you're dealing with a soft tissue neoplasm. These are often large lesions, and the geography of these lesions can change depending upon where you are in the lesion. So that's one thing that we always get concerned when dermatologists start biopsying soft tissue tumors, because you have to take a deep incisional biopsy. You sometimes have to do imaging studies like MRIs and things of that nature to make sure that you're hitting the most aggressive area of these tumors, because it's so easy just to miss something like that with a punch biopsy, which is the vast majority of the type of biopsies that dermatologists are doing, punches and shaves, obviously. Okay, this next lesion is kind of an interesting one, and it's different. This is in the same category as a neural lesion, but it has a different morphology altogether. Instead of having a spindle-shaped morphology like the Schwann lesions we just saw, this one has got cells that are round and have abundant granular cytoplasm to them. So this is a granular cell tumor, and this is a lesion that is also thought to be in the Schwannian type lineage, if you will. These cells, actually kind of what people think happen here is that there's a degenerative phenomenon, and there are cells that engulf these breakdown products of myelin, Schwannian differentiation. So these are Schwann cells. They start producing the myelin they're supposed to produce. Something goes wrong, and they basically produce all of this material that gets engulfed by probably some macrophages and other cells in there, producing this granular cell morphology here. And it gives you this morphology that you see here. A beautiful example of that. It kind of gives you this kind of pinkish to bluish gray. Sometimes it's pinker than this. This one's more of a gray color, usually with a round central nucleus. And notice that there's no spindle cell morphology here. So these really are not Schwann cells themselves. These are probably histiocytes or cells in the macrophage monocyte category that have engulfed all of this myelin breakdown product. And if you look at this under electron microscopy, all of the granules are lysosomes in here. So this is granular cell tumor. And if you stain these lesions, they stain positively with both PAS, because it's the myelin breakdown product, but also with S100 protein. So that's a way that you can actually confirm the diagnosis if you're not 100% certain. Now, a couple other sort of teaching points about granular cell tumors. They're often seen in the tongue, and they're often seen in individuals that are African American. So it's one of the more common benign neoplasms of individuals of color, because, you know, they don't get squamous cell carcinoma, basal cell, those kind of things very frequently, but they do get this lesion relatively commonly. So that's something to remember as well. And the tongue is a common location for this entity. So if you see a lesion on the tongue on a board examination, and then they show you a picture, know the diagnosis. And years ago, we actually used to think this was muscle differentiation, because it was on the tongue where there's a lot of smooth muscle bundles, obviously, and skeletal muscle bundles. And it was thought to be a myoblastoma. It used to be called granular cell myoblastoma, but now we know that it's not caused by that. One other teaching point about granular cell tumor is that you can get granular cell change in other lesions. You can get granular cell fibrous papules, and there are granular cells that can develop in other settings. It can be a reaction pattern. So just be aware of that. There's probably about 5 or 6 different entities where you can get granular cell histology, granular cell atypical fibroxanthoma, for example, and it's not a granular cell tumor itself. And then even though these lesions are large and they go down to the muscle sometimes and fat, they're almost always benign, unless you see areas where there are a lot of mitotic figures, necrosis on moss, things of that nature. These lesions are 99.9% of the time benign. So that's granular cell tumor, also a neural tumor. Now, the next entity is when you get actual neoplasia of the axons. So neurofibroma and schwannoma are neoplasms of the Schwann cells, which are the sustentacular supportive cells of the nerve. So when you think about our cable analogy again, these are maybe the plastic wire on the outside of the little wires where the electricity is coursing through your copper wire there. So the axons are the copper wire. And occasionally you get proliferations of those that cause neoplasms. And these are the ones that are painful. So we're talking about the the painful tumors. The N in there is neuroma. And there's several different types of neuromas. There is the kind of just generic garden variety neuroma where we see this. And so if you look at this, you can see that it generally has very little mucin at all. This is just mainly cells here. The cells, again, look neural. They have that sort of delicate S-shaped morphology. So even though these are not Schwann cells, they have that same type of morphology to them. So again, both a Schwann cell as well as an axon of a nerve will give you that sort of lazy S morphology. Here you can actually see the cells arranged in a small little nerve twig here inside this neoplasm. And you can see the individual cells have that beautiful little S-shaped morphology. So if you were to stain this, it obviously would stain strongly positive for S100 protein again. So even though the Schwann cells stain positively, so do the actual axons, even though they're different cells, they're all part of the same family, same originally embryologic origin, if you will. And you can also do an actual stain for axons themselves, or neurofilament, other stains like that can actually differentiate between an axon and a Schwann cell. So if you wanted to, you could actually distinguish those on that basis. So this one I would just call a generic garden variety neuroma, if you will. Now, there are some syndromes that are associated with neuromas, multiple mucosal neuroma syndrome. If you biopsy those, they kind of look just like this. I don't think they have any specific particular histology to them, but I would recommend that you know those entities for the board examination. They do like to ask questions about syndromes. Okay, this one is also in the family of the neuromas. I go to that one little papular lesion over here. This is probably the most common setting where we see neuromas. This is a really kind of like a little traumatic neuroma. And basically what happens here, and you can see this morphology, this obviously came from volar skin. This most likely clinically was on the side of somebody's hand here, often maybe a young child, an individual. And what's happening here is that this is an accessory digit, most likely, that was amputated in utero. And then the nerves of that accessory digit, that there may have actually even been some cartilage and some primordial changes that actually look like a small digit that was forming. It gets amputated, and then this little papule arises at the side of the amputation. So you can see there's some fibrosis and whatnot up here. And then you get these little irregular nerve twigs at the bottom. And sometimes these are really relatively kind of normal in morphology. They're a little bit larger than normal, but you can see that they're still oriented vertically. Sometimes what you'll see in an amputation of someone like that gets an amputation for surgery or maybe post-traumatic amputation, you'll actually see these axons, these little nerve twigs that are kind of whorled together in a jumbled mass, where they're actually trying to find the other side, if you will. These are kind of reaching for the nerves that are present on this other side of the amputated digit, say, hey, where'd you go? I mean, I want to hook back up with you and form, we want to, repair that telephone wire, if you will. And so they're kind of seeking for those, and they're often, because they're looking, they're kind of traveling in all different directions, looking for where their partner is in a way. So you'll often see a little whorled, irregular morphology to these nerve twigs. These are actually relatively still oriented vertically in this case. This is really the base of the amputation, so they're probably actually growing this way. They're going down here, say, hey, where'd you go? I want to find you and hook back up with you. So that's kind of the way those work. And these are often traumatic. And they can be, these can be a little bit painful as well. So here you see a few of these nerves that are kind of whorled up here, embedded in a scar. That's pretty common that you see that fibrous tissue in addition to the irregular nerve twigs in a traumatic neuroma. And the next one is one that we see clinically of all the neuromas. This is the most common one. And these develop as just kind of non-specific generic papules on the head and neck area, usually of middle-aged older individuals. They come in as a little dome-shaped papule, rule out basal cell carcinoma. They're often somewhat translucent, and this is what's known as a palisaded encapsulated neuroma. So again, these are comprised of nerve axon cells. They're not Schwannian, and they develop, we don't know why, but they get these, we call them palisaded because it looks like you've got all these little nerve twigs at the periphery over here. Encapsulated, it's not really encapsulated, but it's compressing the collagen at the periphery, looking like a capsule, and it's a neuroma. So these are, basically not Schwann cells. These are actually axons. And again, I don't know why these develop, but they come in as little papules on the skin, and clinicians, dermatologists don't learn much about this in their residency program. And so consequently, they don't really know what they are, and they never get submitted to us histologically to rule these out. But it's something that you should think about in the differential diagnosis of a nevus, a basal cell carcinoma, fibrous papule possibly, or an angiofibroma. These all look similar. And when you biopsy them, they look like I'm showing you over here. Here's another example. There's often multiple little, aggregations of these little axon cells, and they have these clefts between the individual nerve residual components here. That's pretty characteristic. They don't usually have much mucin, and these are not painful lesions as opposed to the other neuroma that you see, traumatic neuromas, and also just the generic neuromas. One other neuroma that we don't have here that we could include in a future lecture. I know we're going to be doing some more series of lectures this year. We're going to try not to repeat ourselves and have you maybe view these and then maybe have a new lecture that'll include some additional things. But I would probably add in there a Morton's neuroma, which is a neuroma that develops when you have chronic pressure and trauma on the skin, like people that, especially women that wear high heels, get these ballerinas, that they're putting pressure on certain areas and the nerves start proliferating in an attempt to try to, there's fibrosis and the nerves kind of get damaged and they get whorled, and they try to, heal themselves by forming that. And those are often very painful. So this is another lesion. It's, notice that it has all of this mucin here, and it's arranged in these whorls. And there are these spindle-shaped cells within these mucinous areas. Again, we'll see if we can find some of the more delicate sort of S-shaped ones. Some of these are fibroblasts and maybe some mast cells in here as well. But there are admixed with these some of the nice little delicate S-shaped cells here of nerve cells here, like this one. So this is what's known as a nerve sheath mixoma. Okay, so remember we've got our cable here, and this is the sheath part of the nerve, and actually just have a very few number of the actual nerve cells, but you've got tons of mucin that's formed. So, again, remember sitting in this little cable, we've got the axons, we've got the Schwann cells, we've got the CSF fluid that's bathing the area, and then we've got fibroblasts and mast cells and mucin in there. So sometimes those fibroblasts and mast cells, they're the ones that produce the neoplasm. And the nerve twigs, there's very few Schwann cells and very few axons left in here. We just have tons of mucin. And if you do an S100 protein stain or maybe a SOX10 stain, you're going to see that those nerve cells in there basically get, they highlight that. So this is just yet another example of one of the neural neoplasms that you can get where the majority of the lesion is the mucin, is the stroma, as opposed to the actual cells. Maybe a little residual nerve twig right in this area possibly. So that's a nice example of this entity. And actually in the old days, well, probably still today, some people refer to this just as a neurothichioma in a way, as sort of I think nerve sheath mixoma is maybe a better term. We're going to talk in the next slide about what's known as a cellular neurothichioma. And again, thich means nest. And so when they say neurothichioma, they're meaning neural nests. And these lesions look different. And here, we're not 100% sure what the cell of origin or / differentiation is of a cellular neurothechioma. It's kind of argued about in the literature, but it looks different than the morphology of the cells that we've seen before. There's no spindle morphology of this lesion. This is and again, these do look like nests of cells. So these kind of look more like melanocytes. in many ways. They're arranged in nests like melanocytes are, but these are not melanocytes, and they do not stain positively with S100 protein. They stain positively with NKI-C3 or CD63, which highlights these cells very, very strongly. Notice that there's no junctional activity, so there's no melanocytic proliferation of the dermatopathological junction. So if you're thinking the differential is a melanocytic lesion, notice there's no evidence of that. Cells generally tend to be a little larger, a little bit more abundant cytoplasm than a typical nevus cell. And they'll often have kind of a trabecular pattern. And trabecula means that there are these little struts of collagen between the individual aggregations of cells here that you see nicely demonstrated in this field here. Occasionally, these lesions can actually have some mitoses in them and can be atypical. And I have I made the misdiagnosis one time of a malignant melanoma in a relatively young individual in one of these because it fooled me because the cells were atypical. So you have to keep it in mind. And clinically, these will often present in young individuals with a dome-shaped reddish papule, often on the head and neck area. The nose is not an uncommon location for these. And it's not a melanoma. It's not even a melanocytic lesion. It's probably a lesion that is maybe one of the sustentacular cells of that nerve. Again, it's not Schwann, but it's maybe some of the another cell that may be living in there, maybe a kind of analogous to a pericyte or something. But it's a nice example of what we see here. And remember that this stains positively with NKI-C3 or CD63. I don't know that you would get this on the exam. It's a little bit esoteric for a resident, but at least you've seen it and you know what it looks like, and it can sometimes simulate melanocytic differentiation. The last one we're going to show you is also a lesion in the neural category, if you will, but it's a different type of entity. And again, notice the type of biopsy here. This was done by a shave technique because the clinician probably thought this was a basal cell carcinoma, and it shows a neoplasm with very, very dark staining purple cells here. This is in the neural crest differentiation. Okay, so we have, if you think of neural differentiation, the vast majority of these that we deal with in dermatology are peripheral nerves. Then we have some of the rare entities that we see rarely in the skin that deal with the central nervous system. If you nasal glioma, for example, and then meningeal lesions, we rarely see these, meningothelial hamartoma, things of that nature. But then we have this lesion, which we do see in the skin, and you do need to know about this. And this is Merkel cell carcinoma, and this is coming from the Merkel cell, which is a cell that is in the neural crest differentiation. It's in the same family of cells that give you the islet cells of the pancreas and small cell neoplasms of the lung and carcinoid tumors. So this is in this category, and the Merkel cell is a neuroendocrine cell that's associated with touch and vibration sensation. Cats and dogs and the whiskers have these very well-developed Merkel cells that interact with their vibrissae that they can then detect movement when they're sniffing around trying to hunt prey. And occasionally that cell develops a neoplasm. And in the skin, it's known as Merkel cell carcinoma. Now, some of these are associated with sun damage, but there's another subtype, and this is the important teaching point, is that it's associated with human polyomavirus infections. And this polyomavirus is also associated with Jakob-Creutzfeldt disease, with a number of other entities, but we now know that it's associated with Merkel cell carcinoma, and it's also associated with trichodysplasia spinulosa. So that's a tip that probably will be on the board examination. So notice the morphology of these cells. They're usually poorly differentiated, basophilic. Most all of what we see here is nucleoplasm, and they don't really have very prominent nucleoli. They can have several different patterns. They can be small cells or larger, more intermediate cells. They have that smudgy chromatin. They can kind of simulate lymphomas. They can look a lot like a lymphoma. They often will have a trabecular pattern, sort of like we just showed a minute ago with that palisaded encapsulated or the cellular neurothichioma. So you'll see the cells are arranged in these cords and strands with collagen bundles between them. I believe the other lesion over here may show that a little bit better. So we'll look at that. And then the other thing to know about these is the staining pattern on this lesion. So obviously these usually get worked up. So there's a little bit of that kind of trabecular pattern referred to a minute ago. They get worked up with, we're going to rule out any kind of a lymphoma. So we're going to might do a stain for generic lymphocytes, such as a CD45 stain, which highlights all lymphocytes. Might do a stain, then we would work it up for the neuroendocrine differentiation. Carcinoma embryonic antigen is often used, synaptophysin, but I like better, personally, we use INSM1, insulinoma 1 marker, which is a nice marker that highlights the nuclei of these cells. It's very, very strongly positive, highly sensitive. It's not specific for Merkel, but it's specific for neuroendocrine differentiation. And so to me, that's the best stain, and we use that in our laboratory now. And then the keratin stains are positive. You get cytokeratin 20 is the one to remember, and it gives you this characteristic paranuclear dot staining. And if you look really, really hard on H&E, you'll often see a little bit of pink dot right adjacent to the nuclei of the cells. If you look really carefully, it's kind of hard to appreciate, but that's what is going to stain positively when you do that cytokeratin 20 stain, and kind of correlates with that. So that is Merkel cell carcinoma. And another important point, there's a new biologic agent that treats Merkel cell. So we do have therapy for it. These lesions often are excised, and then sentinel lymph node biopsies are done. And actually, you can monitor the patient's serology to the polyoma virus if they have it. So it's recommended before you do the definitive surgery that you send off some serum to University of Washington, I believe, is doing this test to see if they have what their baseline titer is, and then excise the lesion, treat the patient, and then follow the titers. And if the titers goes from high to basically 0, it means the tumor burden is obviously minimal. But if it starts going back up, it's a sign that the patient's getting a recurrence. So if you don't get a baseline titer on this, it's kind of harder to follow the neoplasm using those serologic studies. So kind of recommended before we go in and start doing big time surgery that we get the test beforehand. So that's it for neural neoplasms. They're interesting, and there's quite a few of them. We covered probably the majority of the ones that you'll need to know for the board examination today. There may be a few others, and so if we give another lecture on this, we will try to fill in the gap using other entities than the ones we saw today, or maybe show you some different morphologies to similar lesions that we showed today. So thanks again for your attention, and good luck.